It's Monday. All right. Yeah, I think we're on track. Morning, everybody. Thank you for putting up with my weird schedule and everything. So, first of all, for whether you're here in class or watching online or whatever, I owe you a sincere apology because I still don't have your exam graded. However, what I will do as compensation for you is what I'm going to do is I'm going to bump your grade up by 5% of whatever you get on that particular exam. Okay. So again, you've been very, very patient. And so weird things have been kind of going on, but it's kind of like where I dropped the ball on some things. Anything that we need to chat about as far as anything within the program. Everybody have a good spring break.
Sir,
Do something. Gross. You could have had snow here. True. Yeah. Everybody do something for yourself. Okay. You did what? Ooh, look at that. Your wedding, your marriage has lasted longer than like 60% of celebrity marriages do. So congratulations. All right. So here's the thing I want you to remember. We're just about into the home stretch. Okay. So in about, won't be next week, but probably the following week, we're going to have an exam. I promise you, we will not have the delays on getting your results back because that exam will be online. The other thing I want to tell you is later today, I'm going to be assuring and making sure that all that your grades are accurate in Canvas. One of the things I noticed for EMC 303 is that the grading scale is still not right. It's showing like if you have an 80%, you have a B, but we have a different grading scale obviously here. So if you want a B, you have to have an 85. I haven't looked at this class to see if that is showing up on Canvas as well, but refer back to the syllabus so that you'll be familiar with what your current position is in the class. So we're going to dig deeper now into specific toxins. I really like talking about toxicology because I don't know as much about it as what I would like to, and that's why I like learning more and more about this. Now, as far as when we're looking at toxicology, obviously the very first thing you got to remember is anytime that there's any type of an exposure, whether it's accidental or intentional, whether it's drug related or whether it's industrial, you got to maintain your own safety first as far as when you're looking at that. Again, the thing you got to kind of remember in this regard is when you're going into a hazmat type of incident, you may not know it's a hazmat type incident until you get there. I can remember one time I was supervisor in Georgia and a crew of mine got dispatched to a call of chest pain. Well, the reason they got called to a chest pain is because a meth lab had exploded, and the meth heads knew that if they called it as an explosion, that would bring in law enforcement, that would bring in fire, and that would bring in EMS. So they smart enough, they called in chest pain. So now I've got two paramedics that are exposed to the chemicals from a meth lab. And understand that those things can change really, really quickly whenever you're dealing with this. Again, make sure that you are safe before you go through. And again, even if we're dealing with a simple response to a home, keep your head on the swivel as far as when you're looking around. And the scene is never really safe. That's going to be the key that I want you to understand. Always, always be looking around. Now, when we're looking at as far as scene safety, again, like I said, situations in a residence can involve drug labs, they can involve hazardous materials, they can involve different types of crimes and things that are going on. Now, the thing to remember is that if you find yourself in a toxic situation, the safest thing for you to do is to retreat, get out into a safe area. And in particular, we're talking about toxicology here now, not so much from violence towards you, but again, being in an unsafe environment. Basically, what we're concerned about is absorption through the respiratory system and absorption through the skin. Get out into the fresh air, and that will be the things that will be the thing that will be the best for you. Understand that some of the patients that you pick up, some of the toxin or whatever they're dealing with may be on their clothes. So before you put them in the ambulance, if you are concerned about that, get them naked. Have the fire department come in and decon them. The fire department are going to be your experts in decon, more so than if you're just straight EMS. So have them come in and decon it, because the last thing that you want to do is to take a hazmat environment from a scene, put it in the back of your truck, and then take it to the hospital, because now we've just made a bad situation that's going to be worse. Again, so let's look at some specific types of toxins. Now, we're going to be in toxins this week and next week, because again, there are so many of them that are out there, and we look at them much like I shared with you on the video for Monday. We look at them from an approach of toxidromes, of clusters of those types of toxins. But we don't want to break them down, because there's some that have specific different types of signs and symptoms, as well as some will have some specific treatments that you're able to do. Now, the alcohol that is drank by humans under most circumstances is ethanol. Methanol itself is a very poisonous type of alcohol that can cause death from the first time that will come about. So now, alcohol itself is not actually recognized as a poison, but what we actually do is, it's when either alcohol is drank inappropriately or too much alcohol is consumed by the patient. And again, so basically what we characterize alcohol misuse as is if it is a situation in which the person that's drinking alcohol could hurt themselves or somebody else. Okay. And that's generally going to be the same definition that we're going to utilize when patients are having behavioral emergencies. Are they going to hurt themselves, or are they going to hurt somebody else? And so those are the kind of things that we look around. With increased alcohol usage, we're beginning to see, and have seen for a number of years, a bunch of new types of disorders. One of the big ones that you may come into contact with, especially when you're dealing with kids, and you need to be aware of this as you're progressing in your careers and your relationships, and you're deciding to have families, is the fact that alcohol, and I'm not opposed to people drinking alcohol. I don't drink alcohol because I don't do much of anything in moderation. Look at me. I mean, I love ice cream. But if you are planning on having children, understand that when the child is developing, alcohol consumption can have a really, really devastating effect on that baby. My wife and I adopted 4 kids. All 4 of them suffered from fetal alcohol syndrome. 2 of the boys died. One had a really rare heart defect. The other basically inherited that tendency for that and died of an overdose. So I had 2 boys, 2 girls, and then we had one child of our own, a biological child. And so of the 4 we adopted, only two of them are still alive, and they both have certain types of psychological and behavioral problems. So that's just why I just share that with you, just so that you'll know going in that alcohol issues can range from really mild to severe, because it does have an impact, just like everything else that we're putting into our body, from water to air to caffeine to whatever we're consuming, has an impact on the brain. The other thing I want you to understand, alcoholism is a free market or a fair disease. It affects the guy that lives down under the bridge, and it affects the person who lives in the most expensive house that you can ever imagine. So again, don't be thinking that, oh, well, this person can't be an alcoholic because they're wealthy, they're well known, they're respected. everybody is at risk for becoming addicted to something, but in particular with alcohol, because it is so freely available. So, what are some of the warning signs that we see in patients who consume alcohol, who become an alcoholic? Is that if they consume large amounts of alcohol over a long period of time. Now, understand, some people are predisposed genetically to alcoholism. My mother had a problem with alcoholism, which means I'm predisposed to it as well. And that's typically why I don't drink alcohol. I don't want to take that particular risk. But again, we're looking at people who have a long-term relationship with the inordinate amounts of alcohol, and their focus is on how do I get my next drink? That's the thing that they're kind of looking at. When we're looking at these folks, and typically what happens is that as people now become alcoholics, they begin to withdraw because their behavior now begins to become more socially unacceptable. Maybe they're not a happy, shiny drunk, but they're an angry drunk that nobody likes to be around when they're intoxicated. So the things that we're looking at is really important as far as their behavior. The thing that you need to assess on all of your patients who fall, whether it is the guy from underneath the bridge, or if it's me, your instructor, or your pastor, or whoever, is that anytime somebody falls, you need to assess for the potential, do they have an alcohol problem? Now, let me ask you a question. Why would I say that? Why am I telling you this? That's a blanket statement that you need to assess. There comes Crash now. Why would you squirrel? Why would you need to assess fall patients for alcoholism? Bleeding source, especially where? Absolutely. Good, gentlemen. Very good. So alcoholics fall down, go boom on a regular basis. So this is one of the things, and again, these are hard questions that sometimes as healthcare providers we have to ask. Sometimes people are going to get offended when you ask them this, but you got to explain to them. These are just questions I got to do as part of my assessment. Because again, it may help you to identify a person who may be having problems with alcohol. And much like Holly and I were talking today, talking about repeated head trauma causing incidents of PTSD. They were doing a study with the military. Again, this increases the possibility of intracerebral bleeding because alcohol will act as a type of an anticoagulant that will increase bleeding. Good pickup on that. Yes, sir.
So type of seizure that alcoholics have to go through withdrawal.
Absolutely. We're going to talk about DTs today. So they will go through it and understand withdrawal from alcohol and withdrawal from benzos can kill your patient. Good point. Very good point. So again, that's going to be really important that when you deal with these patients that are going through withdrawal, that you see them as the true medical emergencies that they are, and not just a nuisance drunk that is interrupting your day. Travis.
Aren't they at higher risk of brain trauma because of Wernicke's encephalopathy?
Ooh, what is that? Travis asked about Wernicke's encephalopathy. You're right. Now tell me more about that.
Essentially less brain fluid causing more trauma.
Alcohol will dehydrate you. Long-term alcohol will actually cause shrinkage of the brain. That's why I love being around you guys. You guys are really smart. And when the brain shrinks, guess what? We've got more room for it to slosh around in the skull. And remember, in the skull, we've got nooks and crannies with, it's not really sharp, but it will cause some minute tears in the brain tissue. So when a person falls down, now what happens is there's more room for those coup contra coup injuries that we talked about in trauma. So again, that's another reason why we want to assess our patient for that has fallen for the possibility of alcoholism. Good point. So generally what we're looking at here, first of all, we know that alcohol is a CNS depressant. Okay. And basically what happens is it impairs the frontal lobe. The frontal lobe is where we make our best decisions. Now, ladies, one of the good things that you have on us as men is your frontal lobe develops and matures about 3 to 5 years faster than men do. This is why men don't live as long as women do. Okay. We just don't make the right decisions when we are young. Now you guys are moving into the age, whether you're male or female, where your frontal lobes are pretty much matured. Everybody, okay. Jake says no, not yet. I give yourself more credit. So again, you heard me brag on you all, and I don't brag necessarily. But again, this is the thing you got to kind of remember. Did a study several years. The government did a study several years ago, and they spent millions of dollars to determine that the frontal lobes of male teenagers didn't develop until they were up into their mid-20s as a general whole. And I said, any parent of a teenage boy could have saved the government tons and tons of money and told them the exact same thing. So again, when we are using alcohol, it helps to reduce rational decision making. Yes. Genetics, typically, and I don't entirely know the reason why, other than the fact that there are some theories that say that because years and years ago, hundreds, thousands years ago, uh, females were basically genetically predisposed to having um, the frontal lobe to develop much quicker as part of their survival mechanism. So, good question. Very good question. People use alcohol for social comfort. When we're stressed, we fall back on what makes us feel less stressed. When we're anxious, we fall back. For me, mine is food, and especially carbohydrates. For some people, it is alcoholism. Now, understand that generally what happens with people that are alcoholics is that they begin to become psychologically dependent upon it first before they become physiologically dependent. Understand that both can be very, very hard to break in the person that basically becomes dependent upon it. The other thing is, especially down with the social benefits of it, is that it is often described as a social lubricant. You've probably heard the joke that the more person drinks, the better dancer that they become. Well, not really, but in their own minds, maybe it does. So basically, many times people who suffer from social anxiety feel like that they have to have alcohol or something to be able to interact with people. And that's not always going to be the healthiest way to do that, because the risk is going to be that's what they're going to become dependent upon instead of seeking out other areas of being able to do that. So psychological dependence, that's important to remember, typically comes first, and then we move on into physical dependence. Basically, at this point, a person is drinking large amounts of alcohol. When a person becomes physically dependent upon alcohol, this is where the problems from withdrawal begin to develop. And we'll talk about this in just a minute. Generally, what we're looking at from minor withdrawal can go from basically being just kind of restless, being anxious, patients having difficulty sleeping. Sometimes they'll begin to develop some fine motor tremors. Again, keep in mind when you see that person. I was at a meeting over spring break with a person that has a kind of what I would classify as an essential tremor. And my first thought was, wonder if he's got early onsets of Parkinson. Don't know him well enough to actually ask him about that. But again, that's kind of the thing that you want to look at and begin to think of. of your differential diagnosis. Why does this person have these tremors of their hands as far as when they're going into that? When the alcohol is completely shut off, now these patients have some really, really significant types of issues. They can, their blood pressure can go way, way up high. They can begin to have tachycardia. They can begin to hallucinate. And then if it's not taken care of, they move into delirium tremens, which is DTs, which is a definite life-threatening type of disorder, which is characterized by seizures. And remember, when a patient seizes, they don't breathe. Now, understand, many times this person is already going to have been involved with alcohol for a long period of time. There's already going to have been structural changes made within the brain matter, which is going to put the person at even greater risk. And the last thing that we want is to have decreased oxygen going into the brain now to make that bad situation worse. And so this is why it's critically important that you got to stop those seizures, because most of the time the seizures will become a type of status epilepticus. Now, somebody describe for me, what is that? What is status epilepticus? Say it again. When they won't stop seizing, okay? They have one seizure right after another. Now, the definition of status epilepticus is having a nonstop seizure or having multiple seizures without an intervening lucid period, which basically means they begin to wake up when they're coming out of that postictal phase. They'll seize and they'll stop, and then they'll seize and they'll stop. And again, remember, every time that they're seizing, no oxygen going into the brain. This is an overall chart that I just put in here. And again, I'll get your handouts at the end of class. Before you leave, let me run them to the printer and I'll get them back to you. But again, just kind of take a really close look at this and see the different body systems that it affects as far as your patients. In particular, all patients who use alcohol in any manner should be assessed if they have an altered mental status for a low blood sugar, because alcohol definitely impairs the pancreas. It can lead into a condition known as pancreatitis. Alcoholics have pancreatitis. It's an inflammation of the pancreas, which, guess what? If we have a malfunction of the pancreas, we're probably going to have a malfunction of insulin production as well. And as a result of that, you could potentially be dealing not necessarily with just an alcohol problem, but you could potentially be dealing with also a diabetic problem. Watch your patients, especially if you have patients that have been consuming low quality alcohol for a long period of time, for the potential for vomiting and bleeding from stomach ulcers and esophageal varices. We'll talk more about those in just a little bit. The central nervous system is really vulnerable to alcohol. It gets into the system fairly quickly because it's a liquid, and it gets into the bloodstream and it goes directly into the brain. As a result of this, the body's or the person's cognitive abilities will begin to break down the more alcohol that is consumed. So they begin to make bad decisions. Their reaction time begins to slow down. And now, again, this is coming about because the alcohol is primarily affecting the cognitive, the prefrontal cortex of the brain. However, when a person consumes an inordinate amount of alcohol, it also will now begin to affect the brainstem. And the brainstem controls what important functions of the body? Yeah, your vegetative functions, breathing and pulse. We see this in particular with people who are coming from high school and now they're out on their own. They're away from mom and dad and they want to be involved with a group. And I understand that. This is not a criticism of them, and they get into a group that maybe doesn't have their best interest, and they begin to consume large amounts of alcohol, and they've never really drank that much before they get to college. And these kids go into respiratory arrest and unfortunately die, or they fall, they get hurt. And so again, these are some of the things that you'll come into contact with. With these patients, again, some of the other things, you may notice slurred speech. They may misform their words. The other thing to keep in mind is that slurred speech is also related to what other neurological dysfunction. Excellent. So again, when you're looking at all of these, don't look at, say, if we come over to Wyatt and Wyatt's slurring his speech, don't immediately assume, well, Wyatt's drunk again. Wyatt may be having a stroke. So take all the information in and then begin to use your differential diagnosis, because it is possible that Wyatt, it's not likely, but it could be possible that he's having a stroke. I'll let you take it up with him later. You can beat him up if you want to. So again, just don't we the word profile has had a negative connotation, but we just like we do with medication classes, just like we do with toxidromes, we put symptoms in different profiles as well. So you can get all the information that you're going to be able to look at. In particular, the alcohol abuse has a huge impact, as I said, on the GI system. Alcohol is very irritant. I think we probably all know that. You drink alcohol, it burns going down, and over a long period of time, it begins to wear away the lining of the esophagus. And because it sits in the stomach for a little bit longer, it now begins to wear away the lining of the stomach as well. This leads into erosion of that gastric lining, causing inflammation and causing some really, really serious gastric distress for our patients. Basically, what we're start out with is that early on that these patients may begin to suffer from gastric reflux disease. And so they will often complain of heartburn, especially right here in the mid-sternal area. And so again, sometimes it's difficult if somebody is having a burning sensation right in this area. Okay, is that GI or is that cardiac? Or is it both? Again, it comes into play of getting all the information that you can get. The more a person drinks alcohol and the lower quality that it is, by lower quality, I'm talking about typically we're looking at a higher proof, but more waste products that are in it because of less filtering, the greater the possibility is that they're going to have GI problems. And that's one of the big things that we're concerned about, because again, we have a large number of vessels, or we have a number of large vessels that run the length of the esophagus. We have an esophageal vein, we have an esophageal artery. Typically, what happens with long-term alcoholics is that covering of the esophagus wears away, and then eventually either the lining or the outer part of the vein will wear away, or the artery. And now we've got a patient that's got copious amounts of blood in the stomach. The stomach doesn't like blood. And eventually, guess what? All that's coming back out. If your patient already has an altered mental status because they've been drinking, now you've got a huge problem with an airway issue. I can remember, I may have shared this with you in a previous class, but I can remember I work in Dalton. We had a gentleman there who was a homeless gentleman, and he would get his alcohol once he got his check. He would go and he would get white shoe polish and a loaf of white bread, and he would strain the shoe polish through the white bread to extract the alcohol. And that's what I'm talking about, low quality alcohol. Most of that was methanol that he was drinking. And so it was very caustic. And periodically he'd have GI bleeding and be in a really bad shape. So again, we're not only now worried about both an airway issue, but we've also got a hypovolemic problem that's going on with our patient. When we're dealing with, obviously, the liver itself, because again, alcohol is primarily filtered more so by the liver than it is by the kidney. Now, the kidneys still have a role to play in there. But again, within the liver, because remember, the liver helps to make red blood cells, it also helps to make platelets. As such, when the liver now begins to be negatively impacted, now we begin to have some huge issues with the patient being able to clot. So when that comes about, that's another good indicator that we've got something going on as far as the liver disease that comes into play. Liver disease for patients that have alcoholism can range from something as, quote, as simple. It's not really simple. It's not really minor. It's a fatty liver. So basically, fat begins to deliver or to develop around the liver itself, thus impacting its function, all the way up to cirrhosis. I've seen some autopsy photos of long-term alcoholics, and the description in those photos coming and says that the liver upon their death was almost like a solid piece of leather that it had shut down and just did not work. And again, here's the thing you got to keep in mind is that when you're dealing with a patient who has alcoholism, any medication that you're going to give to these patients is probably not going to be metabolized as quickly and as normally as if they didn't have liver disease. Yes.
So where does thiamine come into play?
Awesome. Now, what are you thinking about thiamine? Tell me more where you're thinking.
How you give it to people in withdrawals, but I don't understand what it does.
There is a condition. We'll talk more about this in a minute, but I want to answer your question now because it's a good one. There's a condition known as Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome comes into play here that says when a person is an alcoholic, their body is not able to utilize the glucose that is normally available. Now, remember, we said a while ago that anytime that you got an alcohol involved patient, I'm not saying an alcoholic, but anytime that there's an alcohol involved patient has an altered mental status, got to do a blood sugar. Okay. If you suspect that this patient is an alcoholic, and that suspicion realm needs to be really wide. If you suspect that that patient is an alcoholic, if you give them glucose, what's going to happen is that's going to cause, again, Wernicke-Korsakoff syndrome that can lead them into severe confusion and into seizures because you've just suddenly increased the glucose in the body and the body's not able to do it. So what do? We administer thiamine, and I'm going to give you a drug card for thiamine. Thiamine is just one of the B vitamins that you have to give first. And that allows the glucose to be able to be utilized without causing the mental impairments or the combativeness or the seizures that could come about as a result of Wernicke-Korsakoff syndrome. Now, here's the thing you got to remember. Because remember, I said wide parameter. Alcoholism can happen at any age, okay? Even your all's age, all right? Not intimating or insinuating anything here. I'm just telling you, it can happen at any age. If you have a suspicion that a person who has a low blood sugar, who has alcohol involvement, is an alcoholic, go ahead and give them thiamine. It's not going to hurt them, okay? It's a B vitamin, okay? So give them that first just to protect the patient and to make it a little bit easier. Does that help?
Yeah.
Okay, good. Very good question. We'll talk more about that in just a little bit. With liver impairment, now remember, I said that I saw some pictures and graphics of livers that basically look like leather. The fluid begins to back up in the hepatic system, which now begins to lead into the body, and this leads into what is known as portal hypertension. This increases the esophageal vein runs right off of the liver. And this increases the pressure in the esophageal vein, which can indeed lead now more so into esophageal varices, causing that when that vein ruptures as a result of the patient drinking alcohol, now to begin to bleed. The other thing that comes into play here is, again, we can begin to see jugular vein engorgement when we palpate on the liver itself, because the liver is not able to process the blood. It's just kind of filling it up, acting as a sac. When we push on the liver to palpate for it, those jugular veins will pop up. When we release the pressure, the jugular veins will now begin to go flat. This again is something that's really, really important that you need to be aware of. Again, in this lecture, I've got some expert tips. So again, keep in mind that anytime you're dealing with someone who has alcohol involved, two things. Number one, it's not always just going to be alcohol that they've consumed. Sometimes we mix things with the alcohol that leads into potential bizarre, strange behavior. Don't be afraid to call for law enforcement backup if you're in a situation that puts you into concern. So as we're going through this, when we get to this point of where we get significant amount of alcohol that gets consumed, now respiratory depression is going to be one of the biggest issues that we're concerned about. Travis.
So what do you see if they have portal hypertension?
So with portal hypertension, generally what you're looking at is these are going to be physical findings more so than within their blood pressure. Yes, their blood pressure will be up. With portal hypertension, what you will often see is, again, when you palpate on the liver, you'll see those jugular veins that will pop up. Often, keep in mind that people can have liver failure that is non-related to alcohol. I have a friend of mine right now who used to be my boss when I taught in Kansas, who has liver failure, and he drank alcohol, but he was definitely not an alcoholic. Then he hasn't had any alcohol since his liver failure diagnosis. And so the other thing that we can begin to see with these patients is that they can begin to get an accumulation of fluid in the stomach, in the abdomen, and that's known as ascites. Periodically, what they'll have to do is it gets really, really uncomfortable, these patients, and literally they'll go in with a large needle and drain off anywhere from 1,000 to 2,000 milliliters of fluid that's in the abdominal cavity itself. So those would be a couple of things that you would see with portal hypertension. Good question. Anything else on that? Excellent. Excellent. So again, we're watching for patients who begin to have respiratory difficulties. We're watching for patients that are going to have problems of being able to protect their airway. Anytime that you've got an unresponsive person that smells of alcohol, you treat them just like you would any other unresponsive person. We're always going to be concerned about a person who is unresponsive for vomiting. We're always going to be concerned about a person who's unresponsive for a cardiac issue. We're always going to be concerned about a person who's unresponsive for a low blood sugar. So you're going to do all of these things, and as part of that particular of your assessment. Put your patient into a recovery position if you need to let gravity be your friend, to let secretions drain out, even if they are not vomiting, because they may still be having secretions that are developing. And if they're not able to have a swallowing or a gag reflex, guess where those secretions are probably going to go? Down into the alveoli. That's going to be a big, big problem. Anytime you've got a patient with an altered mental status, and in particular, if it involves alcohol, go ahead and get your suctioning equipment out and ready, okay? Use your Yonkers suction tubing so that, it just has to be clean. It doesn't have to be sterile. So if you don't wind up using it, I'm always thinking about finances and things like that. But you can always just put it back as long as it's clean. It does not have to be sterile. but you're saving those few seconds can make a big difference as far as what you're looking for with your patient. Don't use excessive ventilations if you're having to ventilate these patients, again, because what we don't want to do is we don't want a lot of the air getting down into the stomach, because again, not only does the stomach not, yes, exactly right. Not only does the stomach not like blood, it also doesn't like air. And when that air comes up, whatever is in the stomach is coming up with it. If you're running this call on like Super Bowl Sunday and the guys had wings and pickled eggs and chili, now you got a nasty smelling mess to clean up in the back of your truck, as well as you got an airway issue that's going to be going on with your patient. Watch your patient's EKG, okay? Especially watch for tachycardia to begin to develop as an early indicator of what? Shock. Yes, remember, that heart rate going up is going to be one of the earliest indicators of shock that you've got going on. Now, this kind of goes away from what we had talked about in trauma of saying, you know, altered mental status is one of the earliest indicators. But again, that mental status is not going to be nearly as reliable now, because you've got some type of a foreign substance on board that is already altering the mental status. So that thing is not going to be. So now we're going to fall back and we're going to watch our patient's pulse. Get his blood sugar or her blood sugar and check it often. And again, if you need to, give your patient thiamine first to help to offset Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome is not really common, but it can be really serious if it develops within your patient. Let me stop. Yes, I can, because I've got it right here in my notes. WERNICKE dash KORSAKOFF syndrome.
Okay, I'm lost there for KORS. Me too.
KORSAKOFF syndrome. Yep. Exact same guy. Doctor's egotistical, man. I'm telling you. Kind of like, I'd much rather have a cure named after me than a disease, but hey, to each their own. These were a couple of German neurologists that around the turn of the century began to notice this type of syndrome, and they began to experiment with different things for this. So, expert tip, again, remember, alcohol is only one piece of the puzzle. Okay, look for other things. Don't just go by the odor on the breath, because again, if your patient has a fruity odor, you may think, oh, that smells like alcohol. But in reality, it may be ketones from DKA. Not long ago, there was a lady who died in jail. First time I'd heard of this in decades. They pulled her over for DUI, took her to jail. She was not drunk. She was in DKA, and she died in the cell. And so back in the 60s, this used to happen a lot. But again, this is why many times you will get, if somebody is pulled over for DUI, you'll get called out to assess the patient. And rightfully so, because police officers are not paramedics and paramedics are not police officers. So we all have our own jobs to do. And again, those are the things you want to kind of remember with in there. So alcohol withdrawal. Let's talk about the things that we're looking. So if you've got a person that is a long-term drinker and they stop drinking for an extended period of time, they can go through a bunch of different signs and symptoms for our patients. Seizures will typically occur within about 12 to 48 hours after alcohol is stopped, which tells you how dependent these patients are on alcohol. Now, again, when we're dealing with patients that are having alcohol withdrawal seizures, that approach is going to be the exact same as any patient that has a seizure. So let's do a little bit of review on seizure management. What are your steps that you're going to be looking for in dealing with seizure patients?
Oxygen and airway management, benzo.
Oxygen and airway management. Now, what's the best way to deliver that oxygen? Nasal cannula or a mask?
They're not breathing.
But they're not breathing during the seizure. I'm talking about during the seizure.
It's kind of a double-edged sword because you want to deliver as much oxygen as possible, but they're an aspiration risk, and I don't want a big old mask on their face.
Welcome to the world of EMS and welcome to the world of critical thinking. Excellent. Yeah, you're exactly right. So this is, I'm going to tell you, this is one of the things that when people say, well, when you get out of class, then we'll figure out how to do it in the real world. Well, maybe, because each patient is different. Ideally, put a mask on. Why? Because even though they're not breathing, if we give high flow oxygen, some of that oxygen is going to go down into the alveoli, primarily up here at the very top, and we're going to get some diffusion that will take place. However, it's just like he just said, now if we got a mask on and all of a sudden they start to vomit, guess what? That's going to hold that in there. And even if you're really, really alert and you're watching that and you get that mask off very quickly, now you're going to run the risk of the patient aspirating. So again, I don't have a hard and fast rule to take. So literally, it's just like you said, Blake, it's kind of like it's a two-edged sword. Do I give them a high flow oxygen, or do I focus in on their being able to aspirate risk? I wish I could tell you. That's where you use some of that critical thinking. A lot, especially if alcohol is involved, or especially if alcohol withdrawal is involved. Remember that your patients are more likely to involve if the seizure is brought about as a result of some type of a toxin, whether it is pill form, injectable form, or liquid form. So again, that's going to be something that you got to kind of watch and look. In that situation, maybe you go to a compromise if you've got enough hands, and you could do kind of like Z said, and that was a good idea. Hold the mask on by hand, and that's all the only thing that person is going to do is hold the mask on, so that if they start to vomit, immediately you're able to take it off. Depending upon how many seizures the patient has, is going to kind of guide what your next treatment is going to be. Now, again, airway issues would come into play. What else do we do for seizure care? Okay, put them on the left side, let gravity be your friend, vomitus and secretions come out. Excellent. What else? So we're going to protect them, don't restrain them, but we're going to pat around them, pull them away from walls. If they're having a tonic-clonic type of seizure, put a pillow under their head to keep them from striking their head against the floor. You going to use a benzo on these guys? Why not?
Well, yes, but
Of what? Yes. So that's going to be your best benzo to utilize. Again, understand one of the inherent risks of using any type of a benzo is what? Yeah, but this guy's already got, if they're seasoned, their CNS is pretty depressed. What else? Well, that's part of the CNS depression. What else?
yeah, got the respiratory.
Knock out the respiratory drive. The best way to minimize that is by doing what?
Titrate to effect.
You're getting warm. Travis said titrate to effect. Give the benzo slowly. Okay, give it slowly. And again, you can go up to 10 milligrams if you want to, but if the seizure stops, stop with your benzo. Okay, hold that and you have to give it to them later. But the key thing here is to make sure that you give that benzo slowly. All right. Yes, already they're going to have an altered mental status, and already we're going to have a big issue with potentially the respiratory issues. But again, the other thing to keep in mind is that if this patient has been abusing alcohol, they've probably been abusing other types of drugs. Anytime that you have a person that is a long-time abuser of any type of substance, their tolerance to any medication that you're going to give is probably going to be way up there as well. So you may have to go to the max dose of whichever benzo you're going to do, Versed being the best one of being able to stop that seizure. Now, let me stop there for just a second. Any questions on that?
What if it doesn't stop the seizure?
Well, what if it doesn't stop the seizure? What's our next options? Say it again. Max sulfate might be a good one. Okay. So it's a smooth muscle relaxant. I would probably fall back on ketamine. Why ketamine? And it does not have the same effect on what? Respiratory drive. So it doesn't have the same effect on the brain stem. Okay. So go with Versed first because that's a quicker acting, and it will knock out most of the seizures that these patients are going to be having. But again, ketamine, if you carry it on your truck, that would also be another option. Very good. Any other questions on that? All right, Eli, here we go. DTs. So this is one of the most dangerous types of withdrawal syndromes that your patients can have. And again, two things to remember that can kill you from withdrawal: withdrawal from alcohol, withdrawal from benzos. And this is really important because sometimes you have patients that have, for whatever reason, they're it's not always a drug of abuse. Sometimes you have patients that have long-term problems with severe anxiety, and benzos are actually more addictive than alcohol is. You can easily become psychologically and physically addicted to benzos such as Valium, Klonopin, lorazepam in 30 days. It's going to take you longer than 30 days to get addicted to alcohol. So again, kind of keep this in mind of when you're dealing, and we'll talk about patients that abuse benzos next week. But this is going to be a big issue that you're going to have with patients that are going to be having DTs. With these folks, basically, they have a sudden increase in their blood pressure, and then their blood pressure bottoms out. They'll begin to have seizures. Often they will be very dehydrated. So don't be afraid to give these patients a fluid bolus, because remember, as they're progressing through this, alcohol is also will cause a patient to become very dehydrated because it knocks out their desire or their need for fluid. And so they'll kick up their heart rate, which increases dehydration. It kicks up some diaphoresis, which increases dehydration. So don't be afraid to give them a bolus of fluid if you need to. These patients are dangerous for themselves and for you because they will be having some really vivid types of hallucinations, and the hallucinations are never the good kind. They're always a threat towards the patient, and you may be appearing as the threat. Again, as that heart rate goes up and as dehydration gets worse, cognitive function begins to decrease. It's not decreasing because the patient has alcohol in. That's the whole issue. That's bringing the cognitive function down. And this is increased dramatically if we don't treat it aggressively. So the big thing we're going to start out is we're going to start with the least invasive is our own demeanor. How are we going to approach the patient? So what we want to try to do is we want to try to approach them in a very calm, compassionate manner. We want to try to keep the lights down as low as we can, but you don't want the lights so low that now your safety is put at risk. Okay, so because the lights can be irritant for these patients. If your patient is agitated, okay, or if they actually become combative, now what you're going to have to do is you're going to fall back on, again, either administering a benzo, Versed, or potentially with ketamine. Now, understand this, okay? You've heard me say this before. Ketamine within EMS, for some reason, there was, to me, I felt like there was an unhealthy fixation on paramedics who wanted to say, yeah, I've given ketamine. Yeah, I've given ketamine. And that's never healthy. And I think that's led to some of the problems that we've seen with improper use of ketamine in some of the high profile cases, and unfortunately, some of the high profile deaths that we've seen over the last 5 to 7 years or so. Ketamine is a really good drug. Ketamine is a really safe drug. A car is a really good mode of transportation, as you guys experience on a regular basis because you're active EMS responders. As we experienced with David yesterday, a car can also be a deadly weapon when the wrong person is driving it. So don't be afraid to use ketamine, but don't get into that whole thing of saying, oh, I've given ketamine, I'm a real paramedic now. Because you got to be able to give ketamine based off the right protocol, and we got to give it rather slowly. You can't just slam it in. But again, if your patient is becoming agitated, that's the time to try to get them to calm down from a pharmacological perspective. Now, understand this. With patients that are in DTs, the possibilities that you're going to be able to get an IV or give any IV medicines are going to be slim to almost none. So you're definitely going to have to go with an IM. And this is part of the reason why some of the mistakes have been made with ketamine of dose calculations that were incorrect. Again, when you are dealing with a person that's going through DTs, now basically what we want to do is that we want to get that medicine slowly, even if we're giving it IM. Sometimes that slowly, depending upon how combative the patient is going to be relative. All right. But again, your safety has to come first. The other thing that we're going to be looking at, in addition to dealing with the agitation from DTs, in addition to dealing with the potential combativeness, is that many times these patients' body temp will begin to go up because they're on hyper overdrive. Again, think of heat stroke. Heat stroke is a life-threatening emergency. Patients can experience alcohol withdrawal induced heat stroke as a result of going through DTs. So you got to cool them off and you got to be aggressive about it. Okay. So once you get them calmed down, get their clothing off, put cool towels, wet towels on them, kick the air up in the back of your truck. And so again, be really assertive. And that's probably a better word than aggressive, but be really assertive in your management of these particular patients. Any questions before we switch over into stimulants? All right. Going to the opposite the extreme. Alcohol is a depressant. We're going to talk about stimulants now. With CNS excitation, these patients can take these stimulants that will cause agitation, can lead into delirium. And these patients will often have dilated pupils because the CNS system or the sympathetic nervous system is on overdrive. With these patients, especially in the early stages, they'll be very fidgety and they'll struggle just to kind of sit still. With patients that are suffering from overdoses of stimulants, body temperature goes way up as well. I can remember taking care of a patient in Georgia. Went down to the truck stop and picked this guy up. Very relaxed, very, very calm, but he had been on meth for 6 days straight, had not slept for 6 days straight, and finally said, I got to have some help. And when I asked him, I said, can I help you up in the back of the truck? And I went to touch him with my gloves on to help him up in the back of the truck because he was not in any acute danger. His skin was so warm that it was uncomfortable to me. It didn't burn me, but when we got him in the back of the truck, his temp was 107. Now it changed into an emergency. Because the adult brain does not wear very well at that. The other thing with these patients, again, think heat stroke. Many times their ability to sweat has been shut down. And as such, they may be struggling in doing this. Look at your patient when you're doing the assessment. Look for potential needle marks, not from a legal perspective, but as part of your initial assessment or your secondary assessment, not your initial, but your secondary assessment to kind of give you an idea of how this patient may have been going and to use this. Understand that just like patients that use alcohol, it's a depressant, even though patients that use stimulants, now these patients can often be paranoid, they can be anxious, they can be frightened of you. And so, again, they may be sleep deprived. And we know how cranky we get if we just miss one night of sleep. Imagine missing 6 nights of sleep. And this guy that I was telling you about was just kind of the abnormal one as far as just being able to cognitively hold it all together. Specific medications that we're looking at is cocaine. Cocaine is a local anesthetic, part of the Novocaine type of family, and basically what it does is that it kicks the neurotransmitters in the body into overdrive. And these neurotransmitters that we're dumping into the body are norepinephrine, dopamine, and serotonin. This is why it is such an attractive drug, is that it brings about a sudden onset of euphoria. Basically it's the way that it's been described to me is that everything that you could think about being right with the world is that way, except it's like to the 10th power. And so the big issue that we see here is that these patients also become really, really alert. So they're very cognizant of what's happening around with the situations in their arena, and they have this incredible sense of well-being. Now, the problem with any type of methamphetamine, and cocaine is a type of methamphetamine, is that you have this widespread change from this incredible high to now you go down to the basement for the incredible low that comes about as the drug begins to wear off. Part of the issue, especially with some of the later formulations of methamphetamines, is the body can never get back to that initial high, but it tries, it wants to. The body is always seeking for that very first. This is why for some people to try methamphetamines one time means that they become psychologically addicted to it. And again, a psychological addiction is as tough to break as a physical addiction, and in some people, even more so. Basically, what we're looking at here with patients that use cocaine or any type of meth in that regard is, again, think about what happens when we activate the sympathetic nervous system. Heart rate goes up, blood pressure goes up, pupils begin to become dilated. The body temp also begins to go up. Now, the other thing that happens in this is that it places every organ in the body at risk because of severe vasoconstriction. Anybody remember what meth-induced chest pain is known as from a cardiac perspective? Excellent. Prinzmetal's angina comes about not as a cause of a blockage because of a clot, but because the vasculature is so clamped down because that keeps the blood from going through. What's your best way of dealing with Prinzmetal's angina as far as a treatment? You can start with nitro, but now again, nitro is not going to be nearly as effective as what else? Say it again. Nope, even before MAG, a benzo. Remember, what's the middle layer of the artery made up of?
Muscle.
And why do we give benzos? To relax muscles. So again, if you're dealing with a patient that you feel like is having Prinzmetal's angina or is actually having an MI as a result of cocaine use, okay, you may want to administer a benzo instead of, you're probably going to start with a nitro, but you might, and this would be one of those situations where I'd encourage you to get on the phone or the radio with your med control and tell them, because typically what you're going to see is that people that are using meth are going to be relatively young, usually 30 or younger. You don't see many old meth users. Why? They're dead. Yes, great answer. Because they are dead. So most of the time you will see this in young people, and it kind of gives you an area of approach to go. Cocaine generally can be injected, or it can be snorted, or it can be heated and inhaled. And so again, it can be put on the gums. It can come up in through the mucous membranes. Yeah. Again, working in Georgia, I can remember again another homeless person that had a really, really bad cocaine habit. Don't know why he felt like he needed to show this to me. I wished he would not have had, but he said, "Man, I've been using cocaine for years." He said, "Let me show you what I can do." And he took his glasses off and he took it and he threaded them through his septum in his nose and just let his glasses hang there. It's kind of like, don't do that. I didn't, I took your word for it the first time you told me you're a coke user. So anyway, he you know, and again, he was going through some withdrawal because he had not been able to get it. Another form of cocaine is called crack, and crack is just simply cocaine that is mixed with baking soda and water to make it go further and to make it easier to be able to smoke. Basically, what happens is they'll put this into a small spoon, they'll cook it, and then they'll inhale it, or they'll mix it in quite often with marijuana. And it's interesting to watch these folks that will try to self-medicate themselves because, again, if they embed it into the marijuana itself, they're thinking, well, I can temper what's going to be happening as we're going through this. Now, again, if a patient snorts cocaine or if they put it on the mucous membranes, they'll begin to feel that high somewhere in about less than 5 minutes. So it is a very rapid onset. If they cook it and they're getting the vapors, that high will begin in about 8 to 10 seconds. So there's a big difference. The other thing you got to remember is that when these patients are cooking cocaine, these are not professional chemists that we're dealing with here, okay? And so again, you're going to watch for upper respiratory burns for our patients, okay? And so that could come into play as well. Now, again, we're looking at things that are going on, and basically how long the patient's high lasts depends upon the concentration of the cocaine and how long they've been using it. Generally, a high will last usually somewhere between 30 minutes to about 3 hours. And then comes the crash. That comes the falling down of this. Now, with these patients that are crashing, generally what we're seeing with them is it is followed by depression, irritability, and exhaustion because in particular, the dopamine and the serotonin in their body has been completely used up. When we don't have enough serotonin, this is what leads to depression, whether it is from exhaustion, whether it is from a tendency towards mental illness, or if it's because a patient is using methamphetamine. Again, these patients may be suicidal. And understand, regardless of the cause of the suicidal ideation, you always have to regard patients that are threatening suicide as a risk to you because sometimes patients, again, They're not thinking clearly, but they see you as the obstacle between themselves and getting out of whatever pain that they're experiencing. And if you get between that, they may take you out as well. So again, remember your own safety as far as when you're going to do that. Now, when we're dealing with this and we're looking at these patients that are crashing, these patients may often use other types of drugs to help to kind of offset that. They may be using some oral benzos. Most commonly, what we would see for these patients that would use these would be Valium that they purchased off the street. And again, you don't know about how the quality of the Valium is, nor the concentration of it. So again, that leads into another part of the addictive process. With your patients, again, that are in this particular types of syndrome, especially when they're involved with the cocaine at its highest, again, that body temperature will go up. So if you're called to take care of them when the cocaine levels are at the highest, you always got to remember about that body temperature coming down. Assess your patient for other issues that you would see within this particular types of patient. Also begin to remember that because of their use of meth or of cocaine, whatever type of meth that they're using, we've got to be concerned about cardiac disease as well as a potential stroke. And in particular, with a potential stroke, would be an ischemic stroke most likely. But again, because of the elevated blood pressure, now these patients may begin to have the potential for a hemorrhagic stroke. Also understand that patients that snort cocaine will often have frequent nosebleeds. If you'll think back to what we had talked about in cardiology, I always told you, make sure you get a patient's blood pressure prior to stopping the nosebleed. If they've got a blood pressure like 220 over 110, let the nose bleed, okay? Just let it bleed. Because if you stop the bleeding from the artery in the nose, the next artery that ruptures may be in the brain. And so that's kind of the thing you want to look at and be able to do with those. Again, when we're looking at these patients, assess them for Prinzmetal's angina. Again, quite often they can be complaining of chest pain, shortness of breath, all the typical signs and symptoms of cardiac disease that may be coming along, except they will typically be young. Watch them for dysrhythmias. Don't be afraid to do a 12 lead on all of these patients to look for elevations as well as other types of situations that would come into play here. The other thing that you will see with patients is that they will begin to get a widened QT interval, known as widened QT syndrome. So let's go all the way back to cardiology. Why is that so dangerous for our patients? They run the risk of ROT. Again, when that QT interval gets wider and wider and wider, eventually ventricles are going to say, wait a minute, somebody's not doing their job, and they'll depolarize. They'll throw an impulse out there, and as such, if it falls on the downslope of the T wave, now our patients go into ventricular fibrillation. Understand, if you'll recall, I said patients that have ROT respond pretty well to early defibrillation. These patients, not so much. Why? The chemical makeup of the heart has changed. So you may have to give repeated defibrillations for this person to be able to function. Sir. Yes. And the other thing I would tell you on this is if you pick up a concern and you suspect that you're going to have this, set your EKG to do a 12 lead every 5 minutes. And what that does is it allows you, because it's going to be difficult for you to assess a QT interval just by running a rhythm strip. But if you do serial 12 leads, you can track the QT width that it will measure for you on that 12 lead. Very good. Yes.
So I'm assuming adenosine out of the question for these patients.
Why would we not want to give adenosine to these patients?
It's probably not going to help because you're just battling chemical.
Yeah, because remember, the big issue here is that even though their heart rate is up, it's not because it is a cardiac issue, it's a neurotransmitter issue.
Would calcium chloride be effective in stabilizing the cardiac membrane?
Why? Why do you ask that?
So why?
So now remember, now calcium does have a bit to play in with the depolarization and repolarization of the heart, but calcium is primarily within the muscle. And so basically we're looking at the contractile force. So with these particular patients, this is going to be, again, one of those situations where giving them an appropriate dose of a benzo can be potentially saving cardiac muscle like left and right. Good questions, guys. Good questions. Understand that, especially if these patients have had cocaine usage for a long time, they may have left ventricular hypertrophy because their heart has had to push against that constricted vasculature for so very long and leading into problems. Last drug we want to talk about here. Travis, did you have a question? Okay. Last one I want to talk about here is MDMA, also known as Molly. It is a synthetic type of stimulant that leads to all types of potential life threats, including malignant hypothermia, which can basically fry the brain, and multi-organ failure for these patients. When these patients are using MDMA, they'll experience agitation, much like we see with other types of stimulants. The big thing that we want to do for these patients is get fluids in them because they're going to be dehydrated, and use benzos for seizure control, and to watch the blood pressure. And then the other thing is that with a lot of these patients, they'll develop a metabolic acidosis. Now, this is typically only going to happen after days of this. So this comes into play as far as your assessment goes. And that's going to be the focus that you're going to have. Last one is bath salts. Basically, bath salts, we've seen them in the convenience stores. It's like cocaine, but it costs a lot less. Bath salts are not to be confused with Epsom salts, two entirely different things. Hopefully people are not trying to smoke Epsom salts. They're not going to enjoy themselves if they do. But the big thing is going to be the exact same type of treatment that you're going to want to take care of in dealing with these particular patients. Sometimes bath salts are sold as plant food, so you may have some enterprising folks that will get this at different stores and things like that. Bath salts can be ingested or taken into the body the same way cocaine can. It can be ingested, it can be smoked, or it can be injected. Again, with patients that inject these things into their veins, you got to watch and look for phlebitis, which is an inflammation of the blood vessels, which can lead to all kinds of major issues, especially related to renal failure. The big thing we're going to do with all of this is this protocol here, of we're going to be looking and going through and focusing in on airway, body temp control, and seizure management. Any questions? So when you guys meet with Holly, do you meet upstairs or in here? Upstairs. Okay, I will print these off and I'll have them upstairs for you before your class. Okay. Any questions? All right. Thank you all very much. I'll see you on Monday.
Thanks, sir.
Thank you.
Because hyperkalemia, the sine wave